Hi, Dr. Pelman.
Hi, Darryl.
Hi. So good. Thank you for being here. Thank you for taking time to be part of our conference. Welcome to the conference. Can you tell us what kind of doctor you are and where you practice?
So I am a clinical professor emeritus now, at the University of Washington, Department of Urology. So I'm a urologist, and I practiced over 33 years in the Seattle area. I have had hundreds of patients who've undergone prostate biopsy, which is what we're going to discuss today, and have treated men for prostate cancer for over 3 decades. I'm happy that you have biopsy as a tutorial because that's one of the concerns that men who are worried about prostate cancer but don't pursue diagnosis is the biopsy. They all have a preconceived notion about what a biopsy is. And I think as we explore that today, we'll talk about actually the mechanics of a biopsy, what it is, and take some of the fear factor out of it. I think one of the interesting things to do about prostate biopsy is to do a little history about it, and that goes along with a little bit about the diagnosis of prostate cancer. When I was a resident, we found prostate cancer by a prostate nodule on a digital rectal exam, meaning a palpation of the prostate with a finger felt a hard area. And historically, 50% of hard areas were cancer, 50% weren't. And we literally put a needle on our finger, guided it into the prostate through the rectum, or sometimes the finger was in the rectum and the needle went just above the rectal plane through the perineal skin to the area where we could feel. Now, we were only finding the cancers if we could feel them. Along came PSA and the ability of the urologist to do a biopsy, not just aiming at a specific area, but to detect hopefully prostate cancer in an earlier stage, hopefully equate to more cures. We had to develop a different way of doing biopsies. Well, coincidentally came along prostate ultrasound. And I remember arguments about what did prostate cancer look like on ultrasound. So ultrasound did demonstrate some prostate cancers. It was actually an echo pore area. And the technology evolved to be able to slave a little sampling device called the biopsy gun, taking a little sample biopsy along the ultrasound wand transrectally so that you could aim at the area the ultrasound saw. So we'll get to a little more of indications for prostate biopsy in a second. But let's go to the scenario where you aimed at the area that was echo poor, and indeed it came back positive. We would have in the 80s and early 90s correlations with our pathologists, the radiologists. They weren't involved, the urologists were doing the biopsies. So the urologists were there, and we would show the pathology, and the pathologist would say, so show us your ultrasound. Is this the area that you saw? We said, yeah. And they said, well, did you see the cancer over here and over here and over here? And it became very clear that ultrasound did not see all the cancers, and we needed a different method for finding cancer in the prostate. And that evolved into a template for sampling. So indeed, if we see a suspicious lesion, we'll always aim at it. But generally, most of the prostate biopsies that are done are using a very sophisticated pattern or template of sampling the prostate in a very unique way to uncover as many of the cancers we can to decrease what we call false negatives, meaning we tell you you're fine, but we missed it. And that rate holds for a first round of biopsies taking anywhere between 12 to 14 cores of tissue, these little micro samples. Leaves the false negative rate, meaning we missed it, to about 20%. So if you let me now go back, that we have a little history of where we are.
Well, let's just sort of clear up some terms for our audience.
Sure.
Transrectally means like you're going up the rectum and you're shooting a needle through the rectum into where you believe the prostate is.
So I'm going to share my screen if I can do this.
And you could show us that? Okay.
And I'm going to show you.
Cool.
If I can remember what we did to get to that area. Share.
So
And this
you
is a
very
little,
good.
and really you're laying on your side, not like this, but you're over on your side, laying in the doctor's office, draped, and we'll go through some preparation. But when I say transrectally, the ultrasound wand is about a little digit sized, or maybe a digit and a half size, that goes into the rectum, only as far as a finger would go when you're examined by your urologist or primary care doctors. And that sends a sound image to the prostate, bounces back to the transducer of the ultrasound wand, and shows up on a screen. So as a urologist, I'm both manipulating the wand and looking at the screen, and I have the ability to see the prostate in two different modes. We can have a sagittal mode, transverse mode. In other words, cutting a piece of bread from heel to heel, or cutting it from side to side. When we're cutting it from side to side, we're looking at it as we would to do our biopsies. So we can see the prostate, and we can know whether we're aiming at this area called the base. And I'm going to scroll up here and take you to a template or another picture, whether we're aiming here at the base, the mid, the apex, and of course we're right down the middle. We're really off to the left or right side, and that shows up on the screen. And the template was developed as a sophisticated method to sample correctly 2 areas in the base, 2 in the mid, and 2 in the apex. Most people take 12, some people take 14. And then there's some exceptions where somebody may take an extra couple of little snaps in order to have more particular tissue from an area of concern. And we're going to go into that. So I'll stop distracting us with pictures for a second. And when I go back to a template, I'm talking about the urologist who's taking the samples has a very specific pattern that they're sampling in to give us the best information. That's modified by somebody who's having a repeat biopsy because of either they've had cancer found in a particular area, or they've had some diagnosis on their prior biopsy of a form of atypia. And that form of atypia may lead us to go back and resample that area because the risk that surrounding that area atypia could be some cancer. Most commonly, that's called atypical small acinar proliferation, or ASAP. But as far as going now to the biopsy itself and the history of same.
Well, let me interrupt you because I don't want people to sit in a fog for 20 minutes until we get to the end of this and then ask. I mean, it's useful for people to know when you're talking atypia, it's atypical, it derives from atypical, meaning unusual, meaning suspicious. Is that
So
fair to say? All right.
pathology comes back and either cancer, and they grade the cancer, and that's a discussion I'm sure you're having on diagnosis of cancer.
Yeah.
There's then sometimes, hopefully benign tissue. And sometimes there's areas of inflammation that aren't clinical. They just call it inflammatory. They see white cells around the tissue, so it's subclinical prostatitis. And there would be times that they call it atypia. In my era of training, it was just atypia, but as we evolved with more biopsies and pathologists were able to see similar changes, they name it, they circulate it, they all learn it, and they give it a name. And as they see those changes that are consistent, then they call it either PIN or ASAP. Those are the 2 most common subtypes of atypia.
And could you, I mean, many guys get a PIN, written down on their biopsy report.
Yeah,
Go ahead.
we're much less concerned about high-grade PIN than we used to be.
Yeah.
It really, the type that we're more concerned about now is this type of atypia called atypical small acinar proliferation.
So can you tell us what PIN refers to and what ASAP refers to?
So they're
What
just, if we were to share the screen again and look at histology or
before?
microscopic pictures, and I think there's one there. Give me a moment and I'll try to go through where I can find it. But remember that these tiny little microscopic cores are about 1 millimeter wide, and they're worm-like, but very small. They're not very long. They're placed in a process where the tissue, here's a series, you see what I'm looking at here. So they're showing this is the core taken here. These are placed in a situation in the pathologist's office where the technician will, each of these is in a little vial. They get stained, they get embedded in paraffin, they get cut in paper thin sections, paraffin meaning wax, so that you can see through it, putting it on a slide and looking at it under a high-powered microscope. And when you do that, a pathologist is trained to be able to observe the tissue and say that's normal benign tissue, or that's one of these forms of atypia based on microscopic changes, or that's cancer. And I don't want to spend a lot of time looking for the correct microscopic slides since we really want to concentrate on biopsies. Yeah. But it's somebody who's very educated, who knows what they're looking at, who makes those calls. And if it's cancer, most institutions, most pathology office will have a double read on cancer. They'll have somebody else look at it. They just hand them the slides and say, what do you think? So they get an agreement. But now, if I can go back to the biopsy, and we're going to get to indications, and we're going to get to some of the risks and some of the complications, and we're going to talk about a term called shared decision making. But I do want to say that along with the sophistication of using ultrasound guided biopsy, meaning the ability to slave the ultrasound to the sampling needle, we also developed the ability to anesthetize the prostate and introduce local anesthetic. We didn't have that initially. We probably went a decade where we just did it with local, maybe some local gel in the rectum. But in the early 2000s, when biopsies went from 3 on each side, so you had 6 little snaps, to 12, we ended up then learning that we can inject local and properly numb the prostate and really make it a very comfortable procedure. So people who fear pain say, well, don't I need to be under anesthetic? Don't I need to have a sedation? You don't. The introduction of the local has been terrific. And I think if you're prepared for having an ultrasound probe in the rectum, like an examining finger, that the addition of the little sampling snaps that happen as the needle penetrates the rectal wall and goes into the prostate and takes little snaps with local is not painful. We also developed the ability to make certain that we did everything we could to prep somebody to spare them a side effect of infection by giving appropriate antibiotics. And there have been a number of schemes of antibiotics. And I don't want to forget to mention to those who are listening that you all can go to auanet.org, that's the American Urological Association, and you will see a header for education. And if you click on education, it'll bring up best practices, white papers. If you look under guidelines, you can find the early detection for prostate cancer, and you can find a specific one on indications for prostate biopsy of antibiotic use. That was actually a best practice paper. But if you go to guidelines in the early detection of prostate cancer, you will read about biopsy and complications. And one of the things we do is give antibiotics, limited, but we use fluoroquines. Cipro would be the most common that people take, ciprofloxacin. And we use a little enema just before, a little fleets, not a big return enema, just something to clear where a finger would go so the ultrasound probe is able to get a good picture and a good window. And that's really it. I mean, there's not a lot of other preparation other than you should make certain that you're not on aspirin or blood thinners. Or if you need to be on aspirin, let your doctor who's going to be doing the biopsy know exactly what you're taking. We usually will stop blood thinners, and most of the cardiologists who want people on blood thinners okay it for a short time. But again, you always want to check with your practitioner. But as patients, you need to let your physicians know what medicines you're taking. So with an antibiotic starting the night before, the day of, with a little Fleets squeeze bottle enema taken a few hours before, you have your ultrasound performed with the biopsy, and you go home and you go, what do I expect? And we'll talk about some of those as far as issues after biopsy. I'm going to jump back now to who needs a biopsy. This is going to generally be driven by an elevated PSA in this day and age. So first-time biopsy is more than likely either going to be because of an abnormal PSA or a change in PSA that your practitioners deem too great a change from the previous PSA. There are some additional reasons that you may have a biopsy. And as I mentioned, it could be because you've had a previous biopsy with cancer and you're in surveillance. And you are in a surveillance protocol that mandates a repeat biopsy to see if anything's changed. Or because you had that form of atypia we talked about. And perhaps you're at a higher risk group and you had a genetic test. Or you had somebody feel something abnormal on your prostate. Any of those combinations are worth a discussion with your urologist. And that's where the shared decision making comes in, where urologist explains the rationale for a biopsy, explains the procedure that we just went through in detail, and reviews some of the risks and complications with you, and I'll go through those. And you both arrive at, why do I need a biopsy? Where will it get me? What are the potential findings of the biopsy? What happens if it's negative? What happens if it's positive? And what should I expect after? It's very likely that there's going to be blood in the ejaculate after a prostate biopsy. Since the prostate makes fluid for the ejaculate and you're putting little needles into it, it's going to bleed internally. It stops and the bloody ejaculate resolves for the vast majority of people. But it's expected. And patients would tell me, well, you said there was going to be blood. I mean, you should tell guys there's going to be blood. So be expecting that if you look at the ejaculate afterwards, it's going to look red, but it goes away and it becomes old dark blood over time. There's also potential of urinating blood. That is 14 to 50% in the guidelines, and less than 1% of people ever have to have anything done about peeing blood, meaning it doesn't stop, it's fairly heavy, and they have to have a little vessel cauterized. You may have some blood around the rectum. You have a bowel movement or you wipe and you see some blood, because most biopsies are done transrectally. But again, the risk of needing intervention is only about 2.5%, while 30% of people may see some blood, goes away. You just take it easy afterwards. And as long as I mentioned that this was transrectal, there are some other means of doing biopsies. If you're in follow-up for prostate cancer, you may have a fusion biopsy. This is where you've had an MRI that's identified an area where the MRI image is imported real-time onto the ultrasound while you're having an ultrasound-directed biopsy. So it's still transrectal, but you have an ultrasound that also is having an MRI image superimposed, hence fusion, so that your urologist can aim at the area the MRI identified, again, ultrasound transrectally, or can also do standard biopsies at that same setting. So you get the advantage of both. There are people now going back to transperineal biopsy, where the needle doesn't actually go through the rectum. The ultrasound is still in the rectum, but the needle transverses the area just beyond the rectal wall through the perineum, through the skin, and gets to the prostate that way. And you can see the needle on ultrasound and you can see where it's going. And that's really up to your practitioner and a discussion of how they're going to do things. But I would say the biggest, going back to side effects, the biggest concern we have is infection, fever, chills, the overall hospitalization rate because of systemic infection, where bacteria escape into the bloodstream and start multiplying and get you ill, is about 1 to 3%, and seems more likely in people who have had a lot of recent antibiotic use of the fluoroquines, of the Cipros. Those sort of patients who have been recently treated seem more at risk. So there's some precautions that can be done. And if you're in that category, where your practitioner may say, we're going to have you come in a few days before, we're going to do a rectal swab of your rectum with and plate out those bacteria, the rectal bacteria, and we can actually send it to the micro lab and have them tell us if you have resistant bacteria to the antibiotic, in which case we'll use something different. So again, a good discussion with your urologist about what's going to happen, how it's going to happen, the fact that maybe you just had a long course of antibiotic because you had a wound that was infected or some other reason for it. You want to let them know, and let them know what medications you're taking, particularly any blood thinners. So go ahead, and that was a long spiel.
Yeah, not unexpected, but good, I guess. We can certainly take some points out of that. Let's take it from a patient's point of view. They're about to sit on your, lay on your table. Are they in a hospital or in your office?
So the vast majority of prostate ultrasounds with the ultrasound guided biopsy are done in the office.
Okay.
It may be done in an ambulatory surgical center. Some of the fusion biopsies, because of the technology of bringing the MRI on, are done more in a clinic hospital setting. Sometimes it's more difficult to get the pipe with the MRI into a clinic space. But the vast majority are just done in an office.
So the lidocaine or the whatever anesthetic you're using, it goes through the rectum and then into the prostate.
Yes.
So there's a brief moment of discomfort, but not pain. Is that fair to say?
There's a good technique when you're injecting local is to inject, don't wait till you arrive, inject as you're going. So as you're injecting that needle that's introducing the local, as you're pushing it along, it's numbing ahead of itself, and it's fairly instantaneous.
Mhm. And it's numbing the entire prostate, or are you doing it snip by snip?
It's numbing, it's a prostate block. So we're injecting in a very specific area. We know how to do it, and it really helps. Makes a big difference.
Good. And why wasn't that done like 10 years ago as a standard practice?
It came along, I think, in the early, I want to say 2000s, because it wasn't described. Nobody knew how to do it then. So there was actually a paper in the Journal of Urology on how to do this. And remember, ultrasound came along after the mid 80s. I think I got my first ultrasound machine in 1988. So we're using the other technique before that. And we did use local the other way. But nobody knew how to kind of do the prostate block when you were going to do a transrectal using the ultrasound guided biopsy. And once that was described, it caught on and should be standard.
Yeah, because many early guys who had biopsies early on, within a support group setting, will talk about the pain, discomfort. I never want to go through that again. And newly diagnosed guys are guys just wondering, do I need a biopsy? I've got a higher PSA. They hear that and, they're shitting in their pants. They want to, avoid not only sepsis, but they want to avoid extreme agony for something that's just predicated by a blood test, perhaps.
Let me say to those guys who are worried, if we use a 1, 0 is no pain, 10 is horrible pain. Pre local anesthetic, I would get 5s and 6s, occasionally a 7. I rarely got a 9 or a 10. It was uncomfortable, but we were only doing 3 on each side in those days. And it just turns out when we increased with what we call systematic biopsies using this template, that we gave us a better yield and less false negatives and increased the numbers. We also came up with how to block the prostate and use local. And I get routinely, that was not bad, maybe a 1, a 2. If it was bad, it was a 3, but I rarely got anything beyond a 3 out of 10.
Well, that's very good news.
Yeah.
By the way, your internet is freezing up a little bit. Let's see how we can carry on unless you got a quick fix for that.
Uh, internet around here is this is supposed to be up from my old 3.5 to up to 100, but it's been doing its thing, and people have been complaining on the neighborhood blog. So it is what it is.
Okay, we'll carry on. We do remember that you're in Seattle, home of Microsoft and Cisco and all those others.
You think, right?
Yeah, yeah. So,
Okay.
so the SNPs, I mean, it's a spring-loaded mechanism and it goes in and then you pull it out or it returns back into the gun?
So it's called the biopsy gun. It was actually given to urology first as this eloquent little miniaturization of what was called a true cut needle that was used for biopsies, which was a handheld needle where you put the needle in advanced. Imagine a little sharp point, and then there's a part of the needle that has a little missing section. It's here, I'm going to allow me to draw
Yes, please.
because it's eloquent. So, and you look at the dynamics of the old true cut and now the biopsy, the needle was a two-part mechanism needle. And I don't know if you can see my wonderful drawing.
Yeah, that's good.
The needle would be initially flush with the housing, would go in, this would be pushed out, and the tissue would then end up in that little notch, and then this housing would come over to cut the tissue off. Then you withdrew the whole needle, and then you withdrew the housing, and you ended up with a little cord of tissue laying in that notch.
Mm-hmm.
Well, that used to be a hand mechanism. In, slide back over, out, and it was a bigger bore needle. This was all miniature, and everything I just described happens like that. Just like you said, a little snap. Spring-loaded delivery goes out, little piece taken, the housing flies over, pull the whole thing back out. And again, it's going through a guide along the ultrasound wand. So it goes right along the ultrasound wand from outside through, and then deviates. The ultrasound is right against the prostate. That's the transducer. The needle deviates and goes off through the rectal wall into the prostate, takes its little sample, we pull the whole thing out.
Very cool.
And you pull the housing back off,
Mm-hmm.
your assistant is there, you put the little piece of tissue on Telfa, it goes into formalin, goes off to the pathologist.
So, and really good that you illustrate the housing, you know, the sheath, as I understand, as I've been calling it incorrectly, I guess. The idea that when you pull it out, there's a physical barrier between the rest of your body and the sample that you're pulling through
Yes.
the rectal wall.
Yeah, and in fact, that brings up a concern that some patients have read about seeding of prostate cancer.
Yeah.
Again, if you go to those guidelines and take a look, they do talk about it's extremely rare. I mean, given the millions and millions and millions of biopsies, and the fact that, yes, there are certain types of tumors that do seed that you don't want to do needle biopsies on, but prostate is not one of them. And in fact, it's not the standard prostate cancers that seed. If they ever do, this very minute group are variants. They're very strange pathology if they have any tendency, but seeding is not an issue for prostate cancer. We did TURPs. That was a benign operation. We still do it. It's still the gold standard. You go in and you shave the prostate internally through the urethra under general anesthetic or a spinal. Well, you're certainly mixing prostate tissue up with blood while you're doing that. Microscopic cells of prostate tissue must escape during that. We never seeded anybody during that procedure.
Yeah.
So I would tell men who are worried about, oh, the needle's going to drag prostate cancer through, that is not something you have to worry about with a prostate biopsy.
Let's talk about the idea of identifying the location repeatedly, the template, let's say. Is the template a physical thing or something described in software?
So it's a physical knowing areas of the prostate. So we divide the prostate as the base, the area near the bladder, the mid prostate, and the apex. The apex is the edge of the prostate that's closest to where the urine escapes through to the outside world. So your prostate base is closest lying up near the bladder, the mid is the mid, and the apex is towards the exit to the outer world. And we are on the left or right side because the prostate has two lobes, left or right. Occasionally there's what's called a median lobe inside, but we look for the cancers in the posterior part of the prostate, which align right on the edge of the rectum. And we aim very specifically in a certain zone, in a plane where we can see it. And in our mind, we know we're in the base and we want to go the posterior zone of the prostate. We take a couple of samples. We may take a deeper and a more superficial, and we'll take a mid, same idea, and an apex, and then go the other side.
And is there a part of the prostate that you're not able to sample?
So more deeply inside, but even then you can get to it. And some of the fusion biopsies are done where the MRI says, hey, you're back because you still had a rising PSA, a negative first biopsy. And look, we see this lesion and it's more anterior, not the posterior area that usually gets sampled. And there's ways of directing the needle into that area.
Are you able to anesthetize that part of the prostate as well?
You can. It's getting the needle up into there. But again, you're doing more of a prostate block. So just doing the standard block, you can get up there.
So is the idea of not doing a sampling from the anterior, the idea that you want to protect the patient from pain rather than do as useful a biopsy as you can while you're in the rectum doing it?
Well, the idea is that most of the cancers are posterior.
Right, but
That's why the template was developed, and very few are anterior. But occasionally they are, and you have to go up there, or more central. But those are more rare. So the template was really developed for, as Sutton said, go for where the money is, for the posterior. And so the template areas are on the posterior prostate.
So let me just, with not to be obnoxious or impolite, but I mean, let's just drive down a bit on the anterior and sort of in light of President Trump saying there's less, if we do more testing, there'll be more COVID or something to that effect. Is it that we think there's less opportunity, there's less likelihood for prostate cancer in the anterior because we just historically have not sort of looked there?
If you take somebody who's had prostate cancer diagnosed on a standard biopsy and posterior, right? Decided they wanted surgery, which is going to be a different discussion on a different day for another physician to talk about. That whole prostate comes out, right? The pathologists don't look just at the posterior area, they look at the whole prostate. So there are reams of data about looking where it wasn't that somebody said, oh, they're just posterior, don't look anterior. This is through development of where are most of the prostate cancers? The pathologist told us.
Yeah, and it's sort of the joke that the best biopsy is a radical prostatectomy.
Well,
yeah.
So, it does lead us sometimes to need to be more anterior, more central. We know that. But, we're wanting to go and do the best we can. And it's been worked out. That template wasn't just somebody drawing dots saying, well, this would be a good place and this would be a good place. Many templates were developed and looked at. And there was an eloquent paper presented. I think actually David, I think it's David, his first name, Bostwick, who's a pathologist who was at Mayo, who went out and opened Bostwick Labs, reviewed many different templates and yields. And actually the one that we're using is the one we're using because it does have the best yield.
Yeah. And, that also and that brings us to like a really nice feeling around the idea. It's not a random biopsy. It's based on.
Not at all. Yeah. And I'm glad you brought up social media. I just want to make a pitch that there is so much flying around that's non-science. And in the physician community, I think people are finding that patients have heard something on social media and come in and have their own idea, and it's great. We want shared decision making. But if your physician and practitioner can give you data that says what you just brought in doesn't carry any weight, you got to don't keep arguing. It's like they're going to show you data as we know it, that this is, something we study. We go to conferences, we keep up. We don't just say, this is a good idea, I'll go with that. It's something that people come sometimes with preconceived notions, and it's very hard because of the social media aspect to dispel them when you can present data and papers and spend a lot of time trying to dissect through a bias that they've brought in based on something that probably has no science.
Yeah. Let's, I don't want this to end before we hit on three topics that patients talk about a lot. One, perineural invasion. How do you figure that one out? Why you don't biopsy lymph nodes, or do you? And what does it mean? What 5% core, 10% core? Is it 5%, then nothing, then 10% at another section? Let's talk about the geography. Let's start with that one. How do you describe the sample itself?
So the sample, as I said, is going to fill that little notch. And I think the notch maybe is 20 millimeters long, or 22 is millimeter wide. So you're giving the pathologist the job to look at these little micro samples. The histology of the cancer that's found per needle is described, at least currently, with the percentage of the needle being involved with cancer. Now, some labs may do it as an aggregate. They'll take all the needles and say X percent of all the tissue was cancer. But a lot of labs will say how much of 4 millimeters of cancer out of whatever were found. The grading system is a visual of cancer. It's a Gleason scale. And that's a whole, I think you're probably going to have.
Right, we're not going to go there.
Okay.
And we've already covered that in many.
You just asked was,
right. Well, no, the question is in the patient's mind, when they see 5% of a sample, they're imagining like a geologist's core sample of the earth. Right. And they're imagining 5% of 100 milliliters of sample is cancer, and the rest is dirt.
What you want to do is find out, and I always showed the pathology report, copied it for my patients, and the path report, is available for most of the electronic records to look at. And you want to know if the lab that your physician is dealing with reports per total or per core, or maybe both. The lymph nodes are not sampled for a number of reasons. We don't see them on a transrectal ultrasound. We don't know whether you're going to have cancer or not. In most areas where we find cancer, it's early, and there are enough nomograms out there where if you sit then on a cancer consult, meaning your biopsy comes back positive and you're going back to the urologist to find out, is this bad? Is this good? What are we going to do? What are my options? One of the things you can look at are nomograms given the volume of your cancer, your PSA, meaning how high is your PSA, and your Gleason. And you can go to these nomograms with that information and your age and find out what your risk, if you went to a radical prostate, had it removed, where the nodes are sampled during surgery, and find out what percent risk you have of having positive nodes. So somebody who has, say, this will be familiar for those who have people they know with prostate cancer, have had prostate cancer, the lowest grade, stage 1, Gleason 6, small volume, with a PSA under 10. And if you have, maybe 25% of your sample represented with Gleason 6, you have under 5% risk, probably under 3% risk of having positive lymph nodes. So the nomograms do very well, and there's no way that we can actually sample them on a transrectal biopsy. There are situations where people have nodes sampled, but that's more advanced cancer and other reasons for that.
Perineural invasion. So, and in a patient's mind, it's telling him that you're actually sticking through the nerve bundles and in the process disrupting the nerve bundles, and maybe even chance of erectile dysfunction. Can you talk a bit about that?
Yeah, so not true, not true and related. Perineural invasion is a microscopic finding of, take any organ in your body. What does it have? Well, whatever tissue it is, it's got its particular function. If it's heart muscle, it has heart muscle. If it's colon tissue. What else do they have? They have blood vessels, right? Everything needs to be supplied with blood. So microscopically, you're going to see blood trickling through these tissues. Has to. That's how we get tissue to survive. What else happens? You get nerves that innervate or send information to these various organs. The prostate has nerves penetrated microscopically. So when they say perineural invasion, they are talking about prostate cancer cells lying along these microscopic nerve pathways within the prostate tissue. We're not talking about the erection nerve outside the prostate. We're talking about neural tissue inside the prostate. Why is it even commented on? Because it was thought that with higher grade cancers, that one way that the cancer could potentially escape was to creep along the nerve sheath and exit the prostate. So that's why perineural invasion is commented on.
Is the biopsy interfering with the erectile nerve bundles at all?
So erection issues are quoted at less than 1% risk. And it's transient, if it ever happens. I can't say that I've had anybody who ever had a permanent issue with erections. And if somebody had an issue, it was temporary. And I don't even see that many people who would have complained of it being temporary. I'm trying to think back. It just doesn't seem to be a major concern.
Well, so just to drill down a bit, because patients are going to be asking.
Erectile dysfunction as a result of a prostate biopsy is exceedingly rare, less than 1%. And if it happens, it's transient, it's not permanent. Don't make it a reason why you don't have a biopsy.
Absolutely not. But I've got 1,000 virtual guys behind me saying, ask him, ask him, ask him. Does the biopsy needle actually go through the area where, or might it go through the area where, where the nerve bundles might be for erectile function?
They're pretty lateral. We tend to be in a different plane. It could, but it's not going to damage anything, like I just said. But we're really in a different plane than them.
Yeah, good. We're almost losing your internet connection, so I could sort of see you. Yeah, now you're moving. Say something. Let's hear you. Okay, so thank you for this really help. Oh, and it takes what, 30, 40 minutes to complete the whole thing, start to finish?
Yeah, I mean, you're going to come in, standard office procedure, blood pressure, questions. Generally, the assistant is going to get you comfortable, pillow, draped. Physician will come in. I always like to make sure everybody's comfortable. I'll start off with a digital exam with some numbing gel. So not just the standard lubricant, but numbing gel. Let that sit. And we'll introduce the ultrasound one, which has been coated again with numbing gel, which really helps just by contact. And then I'll get some pictures, dimensions of the prostate, see if I see any particular of the hypoechoic areas. And then I'm going to inject the local, and then I'm going to do the biopsies. I'll withdraw that, have you sit, make sure you're okay. They generally want you to urinate maybe before you go. Tell you to go home and take it easy. Why take it easy? Well, we did some puncturing. We want to minimize the amount of blood you pee. We want to minimize the blood around the rectum. We don't want you doing any heavy lifting or straining for 2 or 3 days. At least that's me. Your practitioner will tell you what they like you to do. And then we'll have a result, and you'll get, by most labs, a result by 3 days, 4 days, and you'll follow up with your doc.
Excellent. And no ice cream. You don't give ice cream to your patients or anything on the way out.
Ice cream?
Yeah, you're not giving little treats for a successful thing. I saw several videos of this guy. It's not, I don't want to say the name only because I don't remember it and I don't want to say the wrong doctor. But in each of the video, different patient, different procedure. I mean, always a biopsy. He would pat the guy's butt, and say, "Good boy." And it must have been at least 3 times that I saw something. Might have been a 4th one over the years. And I thought that was the hottest thing, I mean, like, but everybody's got their quirk. Thank you for, we'll get to this. I know, put that down because it doesn't have the thing. So, okay, so I'll edit that out. So if you liked the way Dr. Pelman described how a biopsy is, you could hear him describe even more things through his podcast. And where can people find that podcast?
It's actually Total Men's Health: heart, exercise, diet, genetic testing, colon health. What is your colorectal flora, your microbiome? We cover genetic testing and as it applies to just the whole body, but it's called The Original Guide to Men's Health. So if you go to your podcast app, search The Original Guide to Men's Health, it's under the auspices of our Washington State Urology Society. It's all done as gratis, all experts. We cover all organ systems, good information on how to take care of yourself. So thanks for letting me plug that.
Sure. Look, we had Dr. Walsh for our keynote, and he was plugging a book, his own book. And, I thought that was the cutest thing, I mean, and good information, hard to find. When you find it, you want other people to know about it. So that's, we're all in for that. Thank you very much for your career, and whatever investigation. I'm not sure what your body of research is, but I'm sure it contributed enormously to all of our healths. I think I pronounced that better than hell, but yeah. And I mean, welcome to the conference, and thank you very much for doing this.
Well, thank you for doing this. And all the men who are listening, whether you've been treated, please continue to just make an effort to let other men know that this is available. There's other means of getting information. And the worst thing a guy can do is ignore a symptom or not go in and get checked. So,
cool. All right.
Thank you.
Thank you.